अस्सलाम वालेकुम। तीन दिन में होने की तरह कमी, तो थोड़ा सा टाइम शायद लगे स्टार्ट होने में। हाँ, ये कॉर्नर में राइट साइड पे आप देखेंगे, आपकी राइट साइड पे वाला जो सेंटर है वो पेशावर का है। बाकी ये वाला जो है वो कराची का है। और स्क्रीन पे तो ये स्मॉल विंडो है, वो भी ऑप्शन है कि पूरा जो है नजर आ जाए। ठीक है। वेलकम भाई, आप लोग अपना खाना खाएं जल्दी से। ये इस तरह है कि जो सेंटर संभाला हुआ है शायद कराची वालों ने, ये पहले वहाँ से केप टाउन में कांटेक्ट करेंगे और हमारा क्वेश्चन शायद डायरेक्ट उनसे नहीं होगा, मेरे जहाँ तक अंदाजा है। हमारा क्वेश्चन जाएगा सेंटर में, सेंटर वाले पे उनसे। नहीं, सेंटर से मुराद ये है कि जो कम्युनिकेटर है हमारा अभी इस प्रोग्राम का, जो सेंटर, वो डॉक्टर मकबूल साहब को पता है कौन है। अच्छा, आवाज का वो तो नहीं आ रहा ना, रिफ्लेक्शन तो ज्यादा नहीं है। नहीं, आप समझे नहीं ना। मैं तो आप लोग का इंट्रोडक्शन कराऊंगा। ठीक है। नहीं, मैं इंट्रोडक्शन कराऊंगा। यही है नज़ीर कहाँ गए। और जो स्पीकर है, स्पीकर का इंट्रोडक्शन जो है ना, अकॉर्डिंग टू द एजेंडा तो लिखा हुआ है कि जावेद खान साहब कराएंगे, मगर मैं भी कर दूंगा, मसला नहीं है। अच्छा, वो जो आप बात करें, डॉक्टर जब्बार साहब, डॉक्टर जब्बार साहब, आप जिस बात को पॉइंट आउट कर रहे हैं उसी को फौजिया ने भी जो है ना पॉइंट आउट की है। बाद में डिस्कस होगा कैसे। हाँ, नज़ीर को बुलाना जरा। यार, फोन स्टार्ट होने से पहले क्या आप शावर या कहीं से कनेक्ट करा सकते हैं हमें? आवाज नहीं जाने, मैं चाहता हूँ कि डायरेक्ट उनसे बात की जाए। हाँ? अ, बात सुनो, मेरा नंबर नोट करो तो, 2 7 सबके पास।
अस्सलाम वालेकुम. Okay, I hope कि जो है everyone has had their lunch. Soon we are going to connect with the internet speaker, that is Professor Dr. Richard. And what would be the format is something कि वहाँ से ये सारे सेंटर्स की we have got a screen, और बेसिकली हम जो है वहाँ कराची सेंटर में डॉक्टर जावेद खान साहब होंगे, वो जो है डॉक्टर रिचर्ड इंट्रोड्यूस करेंगे, एंड देन वहाँ वो जो है वेबिनार जो है होगा. वी वांट के इधर जो क्वेश्चन आंसर्स हैं, हमारे अपने इधर पैनलिस्ट मौजूद हैं, आप लोगों के भी जो क्वेश्चन आंसर्स हों वो आप लिख लें, और जो है जो स्पेशल कोई क्वेश्चन आंसर ऐसे हैं जो हम डॉक्टर रिचर्ड से करना है, वो आप लोग पेपर पे लिख के हमें दे देंगे, हम आगे वहां करेंगे. वो डॉक्टर उन्हें जो है व्हाट्सएप कर देंगे, डॉक्टर जावेद खान वहां से उन्हें उनसे पूछ लेंगे ऑन द बिहाफ ऑफ पेशावर सेंटर. So we need because this is basically for a triple combination, that is the new thing, especially in COPD हमारे इधर. So we want के जो queries हैं वो हैं after this session. आप लोग इसमें जो सवाल आते हैं वो भी आप कर सकते हैं, एंड जो आपकी अपनी क्वेरीज हैं वो भी करें. वी हैव गॉट अ पैनल ऑफ एक्सपर्ट्स, जो भी सब आ जाएं तो मैं इंट्रोड्यूस कर दूंगी, ठीक है. एंड वी वांट, अच्छा बस ठीक है, बस बुलाओ. अच्छा ठीक, ऐसे करें कि जो आप बैक पे बैठे हुए बैक वाले आगे आते जाओ, ठीक है, आगे आ जाओ. हाँ, ताकि सीट्स सारी फिल हो, क्योंकि वो अच्छा नहीं लग रहा कि है सून विल बी कनेक्टेड, तो अच्छा नहीं लग रहा होगा कि जो है हमारी आगे वाली सीट्स वो हैं इससे. हाँ, इस सीट से तो कम से कम भरते जाए.
यार ये होगा कि सबसे पहले हम जो है इंट्रोडक्शन कराएंगे पैनलिस्ट का, फिर हमारे जो वर्दी स्पीकर है उनकी जो है ना इंट्रोडक्शन कराएंगे. इन दौरान जो है ना जो मैं बजाज खुद और आप लोग जो पैनलिस्ट है वो इन कांटेक्ट होंगे, डायरेक्ट कनेक्शन होंगे रिचर्ड साहब के साथ, ठीक है. तो पैनलिस्ट में बताता हूँ ना, वो फिर बाद में इंट्रोडक्शन करूँगा. अच्छा, इसके हाँ ठीक है. तो इसके बाद जो ताहिर साहब की रिक्वेस्ट की जा सकती है, अगर कैंडिडेट नाम किसी और का ले लेंगे बिठाएंगे तो.
अच्छा, अभी भी आर जस्ट हियरिंग क्वेटा. ओके, आई एम जस्ट सरप्राइज, ये एआई का जमाना है, मेरी आवाज ऐसे चेंज हो रही है, क्या हो रहा है? तो जो है, अच्छा दैट्स गुड, ठीक है. So just to introduce, and we are grateful and full, Professor Dr. Fazle Mola is here, and he has established the pulmonology unit at Bannu Medical College, and now he is working in the Mercy, and soon that will also be recognized for pulmonology training. Along with this, got Dr. Hamid Binori with us. Thank you, Dr. Hamid. You are here. Well experienced, और जो है जिसे आप कहना कि जबरदस्त clinical practice. अभी मेरे इनके साथ I have got interaction, and there's a lot to learn from him. Hello. So, we have got our guest of honor,
consultant pulmonology,
and
HOD,
okay,
IMC,
no less than Dr.
I welcome you all on the behalf of Highnoon.
Hello,
hello. आप सबसे गुजारिश है कि थोड़ा सा आप अगर आगे आगे आ जाए, आगे की फ्रंट टेबल्स जो बैक पे नहीं बैठे हुए, जो बैक पे बैठे हुए प्लीज आगे आ जाए अगर.
अच्छा, ये अपनों को कह रहे हैं, हम अपने ले आए हैं, ठीक है, ये अपने सेंटर वालों को कह रहे हैं. ओके, सो वी हैव अनदर पैनलिस्ट, डॉक्टर शेर अली. ही इज अ associate professor at LRH. So thank you, Dr. Sher Ali, to be with us, and he's one who has
Assalamu alaikum everyone. I would request everyone to please settle down. We are commencing the webinar very soon. There's going to be one request with everyone to please keep your cell phones on silent mode during the session. I repeat, please, everyone is requested to keep your cell phones on silent mode. Can we have everyone to be please?
Thank you and Asif for coming today on World COPD Day. As you all know, and it's a preventable disease. It's a man-made disease. We can all prevent this disease if we can persuade people not to smoke and make sure that our environment,
before we proceed with the formal proceedings, I
indoor
would
or outdoor, is
request
clean.
one by one to all our expert
Yes.
panelists to please come forward on the designated spaces. I would first of all like to invite Professor Kamran Chima, sir. Sir, please come forward and please be seated on expert panelist. Thank you so much, sir. Now I would request Professor Ashraf Jamal, sir. Sir, please come forward and please be seated. Now I would request Professor Shamshad Rasool to please, okay, he is not here. Yes, he's here, sir. Now I would request Professor Solatullah, sir, please come and please be seated as an expert panelist. Professor Khalid Waheed and Professor Salman Ayaz is on their way. So as soon they resume, they will also be seated in front.
Sadia, Assalamu alaikum. Sadia, your panel of experts sitting on the stage. Is Peshawar rather silent?
Hello.
Yes, Sadia, yes. Your experts, are they sitting on the stage?
Assalamu alaikum, sir. Ji, sir, we have
Walaikum
got our
assalam.
panel of experts on the stage. Yeah, they are
Okay.
Professor Dr. Zafar Iqbal, Dr. Fazle Mola Saab, Professor Dr. Anila Basek, Dr. Oksana Faruqi, and myself, and Dr. Sher Ali as well.
Okay, great. What about Rawalpindi and Islamabad? Over
Alright,
to
so-
Rawalpindi.
Yes, sir. Thank you so much. Dr. Rizwan, can you please confirm if all the expert panelists are seated on stage? Dr. Rizwan? Dr. Rizwan, Islamabad. Sir, could you please confirm if all the expert panelists are seated on stage? Dr. Rizwan, can you hear us? Dr. Rizwan Athar, Islamabad. All right. Meanwhile, all the expert panelists are seated on, in fact, at PC Lahore. Dr. Rizwan Athar, can you please confirm if all the expert panelists are seated on stage?
So all well in Peshawar as well as in Lahore. What about Rawalpindi? They are okay. Can we now move to Quetta? Over to Quetta. Can we join Quetta? Sorry about
Alright,
the.
so Lahore is live right now. Karachi is also live. Peshawar is also live.
तो presentation
Islamabad is
start
also
कर रहे हैं,
live.
आप लोग सारे सुने, ठीक है, फिर उसके
I
बाद
would
आपसे
request
हम-
Quetta station to please respond and please be seated. I would request Quetta if they can hear us. Please unmute yourself. We are formally commencing the session.
Come on.
Uh,
Is there some technical hitch at Quetta? We can't hear you, Quetta. We can't hear you.
Executive Pakistan Center as well. And the last one is Dr. Khalid Ahmed Kakar, who is consultant pulmonologist, and he is a finance secretary of Pakistan Chess Society as well. So
Okay.
we will
Quetta
start
station, can you hear us?
of the Holy Quran.
Can you hear us? Quetta, can you hear us? Okay, let's go to Kesser. Can we in with Professor Richard?
Sir, just we are starting in a minute because the time decided is 2:30. So it's 2:29. We are starting in a minute.
Okay.
From Islamabad.
Sir, all clear. Can we have Quetta to please settle down?
Yeah,
Quetta-
we are just ready. The Quetta Center is ready. I, Dr. Vaitsha is here as a moderator, and our expert panel is there in front of you.
All right. Thank you so much for confirming, sir. We are starting the session. So now I would request to start the session, and it's going to be recitation of few verses from Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين.
Jazakallah khair. Now I would request everyone to please rise up for National Anthem of Pakistan. Thank you so much, everyone. Now I would request Professor Javed. Sir, over to you now. Now the formal proceedings will be as per your cue.
Bismillah ar-Rahman ar-Rahim. My name is Professor Javed Khan. I am Professor of Pulmonary Medicine at the Aga Khan University. On behalf of Pakistan Chest Society and our President, Professor Shini Khan, I welcome you all on the occasion of World COPD Day. As you all know, COPD is the third leading cause of death in the world today. And today we have a distinguished speaker from Cape Town, South Africa, and he is going to address us. And we have people sitting at all four provinces, leading chest physicians in Quetta, in Islamabad, in Lahore, and Peshawar are sitting there. I request Professor Nadeem Rizvi to take their chair. Professor Nadeem Rizvi is one of the senior pulmonologists of Pakistan. Richard, are you there?
I am. Good afternoon to
Oh,
everyone.
excellent. So, excellent. Professor Richard Van Zyl-Smit. If I read his CV, it will take half an hour, so I will be very short. Professor Richard is a professor of pulmonology and consultant pulmonologist at the University of Cape Town and Groote Schuur Hospital, Cape Town, South Africa. After qualifying as a pulmonologist in 2007, he completed his PhD investigating the effects of tobacco smoke and nicotine on human pulmonary defense mechanism on tuberculosis infection. He was supported by an NIH Fogarty Fellowship, and then he completed his postdoctoral fellowship. His major research interests include airway disease, specifically asthma, COPD, with the focus on tobacco, household air pollution, electronic cigarettes, and their impact on pulmonary immune response. After 5 years period as head of the Lung Clinical Research Unit at University of Cape Town, he has done a lot of other good work. He has conducted several research, several clinical trials. He has over 100 peer-reviewed publications. In fact, he has done 130 trials lasting over 16 years. So without any further delay, I request Professor Richard to give his talk on triple combination therapy. Over to you, Professor Richard.
Thank you, Prof. Javed. I really am delighted to be with you all. Let me just make sure that my slides are coming up. You should see a llama and an alpaca. We're going to be talking a lot about the one on the left, the llama, but we're going to be talking about the one without two L's. This one has two L's. So if there's no technical issues, let me dive straight into my presentation. And again, thank you for this opportunity. It would have been delightful to be with you all, but realizing that you are in 4 or 5 different centers in Pakistan, so even if I came across to Pakistan, would not have been able to be with you all. So delighted to be able to do this remotely. And so what I want to do in the next half an hour is take you through a little bit of the background as to how we got to triple therapy in terms of asthma and COPD, and contextualize it in our clinical context. So in terms of conflicts of interest, I need to declare this up front. I have worked, as Prof. Javed mentioned, with many of the pharmaceutical companies on medical clinical trials, have advised quite broadly, and I was an investigator and part of the investigator team on the indicatrol, glycopyrronium, and memetazone studies. So I am biased towards them. I'd like to think that I have experience in them, but I know a lot more about this combination than others, and so may tend to favor it purely because I've had more experience. So we all know about GINA. The GINA guidelines get updated every year, and the context that we're talking about today when we're talking about triple therapy is on the right-hand side. triple therapy is not for the super mild patients. It's for those that have significant disease that are requiring more than a single drug to control their disease. And we are specifically talking about the track 2 here, the regular LAMA ICS combination. So I'm going to, as I said, focus on that spectrum. And when we come to COPD, we are into the new group E, what was a combination of C and D. I always comment that it gets a bit weird now where we go from A, B to E. Our poor children who are learning the alphabet are going to wonder where C and D were, but we're in the severe group there. So let's come back to our lungs. Those of you, probably all of you working in the respiratory space will know this because these are our patients. And your lung function varies over time. It's always lowest in the early hours of the morning and picks up in the afternoon. And so this is a hypothetical 24-hour lung function curve. And I've put in there a trouble line. Now, that is just me putting it in at 850 mils. That's not based on any science. That's just to represent what we know is that our patients get into trouble in the early hours of the morning, then wake up feeling short of breath, needing their reliever. And that's because their airways are narrowed. And so what we aim to do is to, with our bronchodilator therapy, our anti-inflammatory therapy, is to lift this line. We cannot get away from diurnal variation, that is normal, but we're trying to get to our patients to consistently have significantly improved lung function so that they don't get into trouble at night. That's the goal of our therapy. And this pharmacological stenting, as it were, this improvement in lung function over 24 hours has multiple effects, not only symptoms, but reduces exacerbations, improves effort tolerance, daily functioning. And so we really want to try and keep our patients' lung function as good as possible. So going back to when I had just qualified, this is what GINA and GOLD looked like. We had GINA's step 1, 2, 3, 4, 5. We still have. You will notice there that we really only had medium or high dose inhaled corticosteroids plus a long-acting beta agonist. And then horribly at step 5, we had oral corticosteroids as our treatment of choice. And in the GOLD guidelines, we really only had long-acting bronchodilators. We had very little else to support us. Now, thankfully, that's changed. And a lot has changed because of this animal, the llama, as I mentioned. This is the one with 2 L's. The medication we're talking about has 1 L. And so to take you back to your medical school days around muscarinic receptors, there's a lot of good evidence as to why utilizing these receptors is helpful for our patients. There are 5 muscarinic receptors, 1, 2, 3 in the airways, 4 and 5 weirdly in the brain. And there's good data and good pathophysiology and responses to demonstrate the utility of a long-acting muscarinic antagonist in smooth airways, so smooth muscle, submucosal mucus glands, and vascular epithelium. So it has a pleiotropic effect, a synergistic effect with a LABA and an ICS. And so a topic for another day is to unpack this whole little diagram, but suffice to say, there is good evidence from a basic science point of view why these drugs would be useful. And so what I'm going to do from here now is split into 2 separate topics. I want to discuss the evidence for asthma, and then I want to discuss the evidence for COPD. These 2 paintings hang outside my office in Cape Town. And on the left is the depiction of asthma, where the fire is on the inside. We have burning coals in our lungs. We need to reduce the inflammation, so our treatment of choice is inhaled corticosteroids. For symptoms, we provide bronchodilators, and asthma tends to occur in the younger patient with allergies and has significant variability. Obviously, that is a very stereotyped picture of asthma, but a useful concept. And on the right, you can see the depiction of COPD. You can't see the cigarette that is on top of this painting in this picture, but there is a little cigarette at the top of the actual painting, and the fire is coming from the outside. So the treatment of choice is a fire extinguisher. Clearly, we need to stop the cigarette smoking. And then we have to deal with the damage. And in COPD, it's really a floppy airway disease. We've damaged the smooth muscle, we've damaged the elasticity, and so we need a bronchodilator as our treatment option of choice. Tends to occur after the age of 40, needs to have an exposure, and can be quite insidious. And there are lots of challenges related to diagnosis and treatment. So let's focus then on the asthma patient, the fire on the inside, and we'll come back to COPD in a moment. So why a LAMA in asthma? Traditionally, a LAMA was always part of COPD medication, but there's actually very good data to support the use of a LAMA. I mentioned it briefly in the previous slide. This is another very detailed depiction of why a LAMA might work. But blocking the M3 receptor causes bronchodilation, reduces airway inflammation, and prevents airway remodeling. Very important in asthma. And it has a synergistic effect with LABA and an ICS. So if we then go and look at the actual data, there is interestingly quite a lot of data that goes back many years around the development of LAMAs in asthma. And for some reason, I don't know why, it seems to have been picked up more in COPD than in asthma. And now we've caught up with the clinical evidence in the asthma patient. And so 1975, we were already seeing data showing that ipratropium does cause bronchodilation, but we know that salbutamol, a beta-2 agonist, is much better as a bronchodilator than a short-acting muscarinic antagonist. In 1996, tiotropium was shown to protect against a methacholine challenge, so this is protection from bronchoconstriction. And then in 2008, showing that a tiotropium may be useful in the asthma patient. And it wasn't really until 2010 and 2012 where this evidence for tiotropium really came through. And this is the pivotal LAMA asthma study by my friend Huub Kirstens, demonstrating that if you take a patient with asthma who is on a LABA ICS and you add an anticholinergic, in this context tiotropium, you get a significant improvement in lung function, roughly 80 to 100 mils in trough FEV1. So that will prevent your patients from dipping hopefully below that danger line, and a reduction in exacerbations. So this was now back in 2012. And interestingly, in around 2020, they all came out in a relatively short space of time, 3 separate trials from 3 separate companies looking at what is now referred to as single inhaler triple therapy for asthma. At the top there is the trimaran and trigger study. That's Chiesi's drug. I'll show you that in a second. The second paper there is the Iridium study. This is the one that I was involved in. This is from Novartis. And the third one, the Captain study, is the study from GSK. What is important to understand when one looks at these data and to interpret it in our own clinical context is to recognize that for these trials, the inclusion criteria were slightly different. How the trials were conducted were slightly different. And so head-to-head comparison becomes a little tricky because the trials did not all have exactly the same criteria. And so let me take you through each of them one by one and see what we can learn in terms of our own patients. So the trimaran and trigger study were 2 separate studies using the combination of ultrafine beclomethasone, formoterol, the LABA, and glycopyrronium. So this is a twice daily LABA-LAMA ICS in a PMDI, comparing 2 separate groups of mild and severe patients and separate doses. What they demonstrated was an improvement in FEV1, that would not be unexpected that adding tiotropium to budesonide and formoterol should improve your lung function, which it did. For some weird reason, it only showed a reduction in exacerbations in the medium dose, not the high dose. And there was no change in ACQ. Now, it's important to understand that the ACQ, the asthma control, the asthma quality test, has problems in terms of it being used on separate occasions. It's good as a once-off, but showing changes in the ACQ-7 score is difficult and well recognized. So improves lung function and a little bit of exacerbation reduction in this compound. The GSK study, known as the CAPTAIN study, had fluticasone propionate, so fluticasone furoate, FF, umeclidinium, the LAMA, and vilanterol, the LABA. The same combination has been tested in COPD, and I'm going to come back to that a little later. What is important to understand with this particular trial is that they did not require patients to have had exacerbations on entry into the trial. So this trial was not set up to demonstrate a reduction in exacerbations. It did show an improvement in lung function. That's not unexpected because umeclidinium and vilanterol are both bronchodilators. And somewhat weirdly, the ACQ-7 score did improve, but it was a very, very small improvement. So again, we're showing an improvement in lung function, but not exacerbations, but that is because of how the trial was set up. And they've had some issues with registration for asthma because of how they set up their trial. Now, this is where I need to again to declare my biases. These are the what's called the Novartis Platinum studies. I am an author on all three of these publications and so know the data quite well. And this is part of the development of the once daily indicatrol, glycopyrronium, and mometasone, which really is the focus of today's talk. And so the medication didn't previously exist as a combination together. So there was the development of the LABA and ICS and the development of the triple. So very briefly, there were multiple studies that were involved, all 52 weeks for both of the iridium and the palladium, the LABA-LAMA and the LABA-LAMA ICS. 52 weeks, multiple comparisons, and so a very difficult trial to run because patients required several different inhalers. And so before I get into the data, let me just talk briefly about the individual components because that's important when one is looking at this new combination. So mometasone is one of multiple inhaled corticosteroids that are available. The GINA list that you may well be familiar on the right keeps getting updated and changed, and it's becoming increasingly difficult to understand what actually the dose is and whether it's in this low, medium, or high range because the numbers keep changing. So in the old days, it was easy. Fluticasone was 250, budesonide was 200, and you just needed multiples of 200 or 250 to work out where you are. Now the dosing has changed dramatically, and you may notice on the right there in the middle, mometasone furoate depends on the device. And so the device does dictate to some degree the dose that you're getting. But what we know about mometasone is that it's ideally suited for once daily application because it is a high potency drug at the receptor. And there are multiple studies that I don't wish to go into because of limited time, demonstrating their clinical efficacy, both from a lung function perspective as well as an exacerbation and oral steroids. So mometasone is a very useful and very good inhaled corticosteroid for use as a once daily preparation. Indicatrol, originally developed for COPD, is a very potent bronchodilator. These are data from my paper in the Palladium study, looking at the lung function change over time after the first dose. So the bottom two gray lines are just the steroid on its own, and we would not expect a significant improvement in FEV1 after inhaled corticosteroid. The mustard color line is salmeterol fluticasone. Now we know that fluticasone and salmeterol as the combination are effective in asthma, but salmeterol does have a slow onset of action, usually peaking at around 20 to 30 minutes, so not suitable as an acute bronchodilator. If you then look at the top two lines, the red and the maroon lines, those are indicatrol and mometasone. And you can see that by 15 minutes, you have the significant almost 200 milliliter improvement in FEV1 for a drug that works for 24 hours. So interestingly, all of these ultralabas, vilanterol, indicatrol, olodaterol, all have a relatively quick onset of action, but are sustained for 24 hours. So patients will know that they've received indicatrol because their lung function improves quickly. If we then move across to the Iridium study, which had the triple, so now this is indicatrol, glycopyrronium, and mometasone, all three together, you will see that the top lines, the dotted line and the solid red line, is the triple combination, showing that within 5 minutes the addition of glycopyrronium has a significant improvement in lung function, demonstrating the importance of this combination, because indicatrol and glycopyrronium work quickly, they work over 24 hours, and so for patients they will feel the benefit soon after inhaling, which will be sustained for 24 hours. And this for me sets apart this combination because of this rapid onset of bronchodilation in both indicatrol and glycopyrronium, and definitely two together. So it's not all about speed of onset. What about sustained at 24 hours? So this is trough FEV1. This is the next morning. Little bit of a busy slide, but on the left, it's a medium steroid dose of the triple in blue and the double in red, and you can see the added benefit of glycopyrronium there. In the second panel, the dark blue and maroon is high dose indicatrol, glycopyrronium, mometasone versus indicatrol, mometasone. And what's really important is the combination and comparison on the far right, the two graphs on the right. This is high dose salmeterol fluticasone, so that's 5,500 twice a day, compared to a single dose indicatrol, glycopyrronium, mometasone at a medium dose steroid in the light blue and a dark blue high dose steroid. And you can see close to an over 100 milliliter improvement the following morning after a single inhalation of indicatrol, glycopyrronium, and mometasone. Which brings me back to my earlier slide of my hypothetical once daily lung function curve, that these drugs are working significantly better than a twice daily salmeterol fluticasone at 24 hours. So our patients definitely feel the benefit. And this translates into exacerbation reduction. Just focus on the far right, because that's the most illustrative. High-dose salmeterol fluticasone versus high-dose indicatrol, glycopyrronium, and mometasone. The furthest graph to your right, a 40% reduction in all exacerbations. And if you come across to the middle curve, to the middle graph, 42% reduction in severe exacerbations. So this once daily triple combination of indicatrol, glycopyrronium, and mometasone in your asthma patient far outperforms high-dose LABA ICS in the form of salmeterol and fluticasone. And so what happened subsequently in the trials was that they then went to what's often referred to as a more open-label, real-life trial. They compared what is commonly known as a fixed combination versus a free combination. So indicatrol, glycopyrronium, and mometasone in a single inhaler compared to 2 separate inhalers containing a LABA ICS, and then adding tiotropium as a separate. So a loose combination or a free combination compared to a single inhaler. And what they showed in this particular trial was, again, the additional benefit of having all 3 drugs in a single inhaler compared to salmeterol, fluticasone plus tiotropium. Now, my personal feeling is that it's a slightly unfair combination because indicatrol is far more potent than salmeterol. I think mometasone is far more potent than fluticasone propionate, the twice daily. And I'm going to show you a little bit of data later on versus glycopyrronium and tiotropium. So I really do think, and again, this is my personal bias, that this particular combination is a really useful, potent combination just because of the drugs contained. I was taught by my pharmacologists at medical school that there are 2 types of drugs, those that don't work and those that have side effects. All medications have side effects, including bronchodilators, including steroids. And if you're worried about the adverse events or safety of these products, this is the selection of trials in the development. And we also did a specific cardiovascular safety study looking at a pooled analysis of all the data from all the trials, demonstrating the safety of this particular combination. So, as mentioned earlier, I think we have a very potent combination of 3 drugs that is ideally suited to our asthma patients and has significant benefit in those patients who are not controlled on a LABA and an ICS. So let me switch across now from asthma to COPD. Given the focus today on World COPD Day, let's focus now on the options for our COPD patients. This morning, prior to my talk with you, I was involved in a launch of the South African COPD Foundation. We've never had an advocacy group for our patients in South Africa. We have tried as part of the South African Thoracic Society to advocate, but now we have a patient group, and so it was a delightful experience to be able to share the launch of that foundation. And part of that discussion was to recognize that in a country like South Africa, and I think Pakistan and South Africa share very much of similar type of exposures, both being non-super high income countries, that the traditional graph of Fletcher and Pito, and even this newer graph that Gold has put out about lung function trajectories do not reflect the reality of the patients that we see in a country like Pakistan or like South Africa. And so my version of this graph looks like this. If we take an average developed country dweller, we know that your lung function improves somewhere till around 25, and then everybody's lung function deteriorates over time. That's part of getting old, I'm afraid. We know that if you smoke, your lung function drops off faster, and if at some point you decide to stop smoking, you don't go back to where you were, but your trajectory changes. So that's fair enough in a high-income country like the US, Scandinavia somewhere, or the UK. But unfortunately, when you're in a different scenario and you live outside those super high-income countries, you're exposed to a whole lot more than just your tobacco smoke. And I suspect that we, living in lower middle-income countries or even upper middle-income countries, have a slightly different trajectory. Similarly, I think if we have the amount of poverty and malnourishment, many of our children never peak as where they should at adults, so start significantly disadvantaged. You take an individual like this and then you add in HIV and or previous TB, it is further going to have impact on lung function. And as Prof. Javed mentioned right at the beginning, if you add in tobacco smoking and potentially vaping, we have an additional problem. Now, these are completely hypothetical lines from me. It's based on no evidence except clinical experience that many of our patients will never hit the peak that we may see in other countries. And so we have a very different perspective on COPD. And part of that, unfortunately, is poverty that underlines it. Now, all of these exposures may look different in different countries. In South Africa, unfortunately, we have lots of all of them. But it impacts from birth all the way through to old age, these variety of exposures. There's good data about your mother's nutrition when you were in utero, your exposures in terms of organogenesis. All of these impact on later in life. And then you throw in the new things on the block: vaping, climate change and energy crisis, COVID and its impact on lung disease and access to vaccination, global wars and food security furthermore impact all of these. And then obviously the access to asthma medications, COPD medications, and the variety of inhalers that we required. So there's a lot that is impacting on our patients, both as an unborn all the way through to an elderly person. So let's focus then on GOLD and the recommendations for COPD specifically. I always laugh that the GOLD recommendations have this copyright material, do not reproduce, which doesn't allow us easily to use these pictures in our presentations. And that's a unique GOLD thing. Now, thankfully, they're creating some slide decks for us. But the traditional ABCD had a long-acting muscarinic, long-acting anticholinergic in it from 2013. When we get to the more updated now 2019-2020 guidelines, we have this really horrible box on the right where we have lines and boxes and boxes and lines, which really confuses the living daylights out of all of the clinicians in South Africa, and I would suspect that it would confuse the most clinicians in Pakistan as well as to what options are available and how do we get there. So if we go back to some of the original COPD trials, this is now 2007. The TORCH trial demonstrated that adding an inhaled corticosteroid to a long-acting beta agonist improved lung function and reduced exacerbations. So that was a key study demonstrating the utility of an ICS plus a LABA for COPD. Unfortunately, that combination seems to have come at a pneumonia risk, and it's not the best combination. But the data is robust that a LABA and an ICS are a good combination for COPD. Then glycopyrronium came out and was tested in the GLOW trials compared to tiotropium, and demonstrated that glycopyrronium was at least as good as tiotropium. It works quicker, but lung function was as good. I mentioned the issue of side effects. The side effect profile for glycopyrronium is very similar to tiotropium, maybe a little bit less dry mouth, but that's not statistically significant. And in terms of lung function improvement, these are the graphs, non-inferior. Again, the trial was not set up to show superiority, but glycopyrronium, as I said, works quicker and is as good. So we then got to the dual bronchodilator stage, when GOLD switched from advocating a LABA and an ICS to 2 bronchodilators. And this comes from the FLAME study. And it's important to recognize the challenges in interpreting these data. So FLAME was Novartis' study looking at indacaterol and glycopyrronium, two bronchodilators, versus salmeterol and fluticasone. Now, if you remember back a couple of minutes to the asthma data, well, clearly two bronchodilators are going to have much more impact on lung function, indacaterol glycopyrronium, compared to a salmeterol fluticasone. And so what this trial demonstrated was that two bronchodilators, in this case, a LABA and a LAMA being indacaterol and glycopyrronium, outperformed high-dose salmeterol fluticasone in terms of exacerbation reduction. So this is where GOLD switched from advocating a LABA ICS in these exacerbating patients to dual bronchodilation based on the indacaterol glycopyrronium data. So bear with me because it gets a little bit confusing now. Then we had GSK's data. GSK, remember, has umeclidinium, vilanterol, and fluticasone furoate. And the IMPACT study demonstrated that triple was better than double. And this is now why we have that triple recommendation in COPD. What they also showed was that their LABA ICS was better than their LABA LAMA, which raises an interesting question. Is this a drug effect or is this a different population? And the answer to that question is probably yes, it's both. Slightly different population in the IMPACT study compared to the FLAME study. And again, I think personally, my personal opinion is that vilanterol and umeclidinium are nowhere as potent as indacaterol and glycopyrronium. So it muddies the water a little further. And then we have the ETHOS study. The ETHOS study was done by AstraZeneca, which now has a twice-daily PMDI compared to the once-daily combinations in the other two trials. And they demonstrated now for the first time an exacerbation reduction, a mortality benefit, and the impact of eosinophil count in the COPD group. They also showed that the combination of their LABA ICS and their LABA LAMA was not as good as their triple. But again, here we're doing formoterol and glycopyrronium. So again, we've missed out on the indacaterol. So how do we then take all of these data together and bring it back to the patient in front of us? So I've mentioned with asthma already that I think the triple combination really is a very, very useful group of medications to use in patients with moderate to severe asthma. In the COPD population, the combination of a LABA and LAMA in group B is well recognized. GOLD did unfortunately say we no longer recommend a LABA ICS, which is very problematic because the cost of a LABA ICS is low compared to many other combinations. And it doesn't mean that they don't work. And so they have recanted on that statement where triple is best if available. And now in your context in Pakistan, a triple is available, so that's fantastic. It doesn't mean that a ICS does not work. It just means that triple is best. And so if I take the data that I've demonstrated to you, the triple combination is going to be the treatment of choice for those who have frequent exacerbations. That's that GOLD group E, particularly those who have a raised eosinophil count. I'm not sure that we fully understand the context of a low middle income country where eosinophils may be high because of parasites or other exposures. They may be low because of other exposures causing COPD. But certainly if we have access to the triple combination, that would appear to be the best option. And then again, you have this box in lines and boxes where you can, in those severe exacerbating groups, decide between which LABA LAMA or which LABA LAMA ICS you would like to choose. It does get a little confusing, unfortunately, but hopefully I've kind of explained to you how we got to where we are, which will help you make that decision. So I want to finish with this slide and then leave time for questions and answers and the panel discussions, because I think the questions from the group and the panel and the discussion is going to be really important to interpret these data in your local context. So indicatrol glycopyrronium mometasone, a triple combination in a once daily dry powder dose confirming single inhaler, I think is a really useful option. Indicatrol and glycopyrronium are potent calmers and lathers, and mometasone is a well-established inhaled steroid. I think the safety profile is good, and we have evidence to support the use. And with that, I'm going to hand back to the chair, and I'm available for questions and discussions. Thank you.
So, thank you, Richard, for outstanding talk. I'm grateful to you for agreeing to give us some time for the question and answer session. I request our panelists in Karachi, first of all, to take their seat. That's Professor Nadeem Rizvi, Dr. Asif Naseem, Professor Muhammad Irfan, and Dr. Musawwar Ansari. Richard, before we take question, let me introduce other panelists present in other cities of Pakistan. Let me take you to Lahore, where we have expert sitting there. Professor Kamran Chima is there, my good friend. Professor Ashraf Jamal is there. Professor Shamshad Rasool is there. Professor Saulatullah Khan is there. Professor Khalid Waheed and Professor Salman Ayaz, one of the leading interventional pulmonologists of Lahore, Pakistan. So Lahore, we've all seen you, and now I move to Islamabad and introduce our panel of experts sitting in Islamabad, and that's my good old friend, General Jawad Ansari. We spent time together at Birmingham Heartland Hospital, long time back. Dr. Rizwan Athar, Dr. Asma Ambreen, Dr. Kalimullah Turi, and Brigadier Imran. Are you all there? Okay, we'll come back to you for a question-answer session, I'm sure. In the meantime, you can all gather the question from the audience and just put in front of your desk and choose the best questions out of several that you may have received. Now let me go to Peshawar, where we have Professor Dr. Sadia sitting there. Dr. Sadia, are you there? Then we have Dr. Zafar Iqbal, a good friend from Lady Reading Hospital. Then we have Dr. Fazal Mullah there, Dr. Anila Basit there, and Dr. Ruxana Farooqi there. So are you all there? Yes, we have seen them in Peshawar. And now go to the Quetta. We have Dr. Maqbool, our General Secretary of PCS, sitting there, and Dr. Waheed sitting there. And our Dr. Shiri Khan unfortunately had to go for a meeting with the government officials regarding some health issue. So he could not be present. He promised that he will come as soon as he finishes his job with the government. So let me see from where to start. Let me start with Islamabad, because that is the capital. So I take you to Islamabad and see if there are any questions there where Our moderator, Dr. Rizwan Athar, will take you from there. Dr. Rizwan, over to you. Richard, are you there?
Please.
Okay.
I am, yes.
Rizwan,
Hello?
Sir,
Dr. Kaleem is speaking. Yes.
Dr. Kaleem is asking the question, please.
Am I audible? Dr. Zyl-Smit, am I audible to you?
Little soft, but yes.
Yeah, okay. My question is a bit, I mean, we perceive today that triple therapy for both and asthma. We know asthma and COPD are two different things. So in asthma, even if the LAMA has been given, it's in the step 4 of the treatment, because we have to stress more onto the steroids and the LABA in asthma rather than onto the LAMA. So because the message we are perceiving here is that give triple therapy to majority of these patients. So it's a bit of concern to me that even in the guidelines, it's in the step 4, not before that. So we have to stress that for majority of the asthma, the treatment lies in the steroids and the LABA rather than LAMA.
Absolutely. I agree with you 100%. It's one of those strange conundrums where we end up at the same point, but we start at a very different area. And so the challenge with asthma is that the steroid doesn't make you feel better, but the bronchodilators do. And certainly we've seen that where patients have been given tiotropium as well as their inhaled steroid, and they defer to their bronchodilator because it has a clinical effect. They can feel it working. But you're absolutely right. We need to make absolutely sure that inflammation is well dealt with in our asthma patients, and only in those severe groups where we have maximized the inhaled steroid LABA combination would a LAMA be a useful add to that. Certainly not in the mild patients, and certainly not in a patient who is not on an adequate dose of a LABA ICS combination. So I agree with you 100%.
Okay, next question.
So we have another question from Dr. Wajid. Please, Dr. Wajid, consultant pulmonologist.
Thank you very much. Professor Richard, thank you for a very illuminating talk. My question is talking particularly on the COPD day about COPD. You mentioned impact and ethos trial. You didn't talk about tribute. I think there are these are the 3 trials which are actually till to date being discussed. And unfortunately, all 3 have several confounders in their statistics. One, that all of them the patients were not treatment naive patients. All of them had been using ICS in the past. And in each of these trials, there was a LABA plus ICS arm on each of them. The results compared were LABA-LAMA as well as the triple regimen, but the confounder regarding the ICS was not really given that much of, credence, especially in the impact as well as in ethos. And I also share your opinion about the combination, the selection of combination in the impact trial of a very weak, anticholinergic, also not very strong and very fast acting LABA. But please give your comment that is it justified with these confounders to base your opinion as big as an opinion going on to triple therapy in most of the patients with these confounders in the 3 very valid trials that are till to date published in COPD, the tribute, impact, and the ethos. Just one comment also, that I think you failed to mention one thing, that as Kalimullah Turi was mentioning regarding asthma, the Gold has categorically said that we go to triple therapy that only in those cases where your eosinophil count is more than 300. I think that needs to be mentioned here, that triple therapy should be considered in those patients in which your eosinophil count goes beyond 300. And that is one of the limitations which the Gold summary has come out in 2024.
Yeah, I really I struggle with gold, and I struggle with interpretation of these data for the very same reasons that you have mentioned. The inclusion criteria for these trials looks different. The combinations are different. And certainly the eosinophil count is an important indicator in the triple versus double. But again, I don't think we're comparing head to head here. The other challenge is that when we talk gold groupings, we talk, have you got exacerbation 1 or 2 or 3 exacerbations? And if you're a gold B of non-exacerbating, but you are on a LABA ICS, in theory, you were an E. You were an exacerbating person who's now not exacerbating. So you now become a B. And gold doesn't fully understand that interaction. So your preceding therapy, I think, is critically important as to what you are. And if you're failing a specific therapy, then by definition, you're not winning on that therapy. And so your entry into the trial, you are already failing what you're on, and so have declared your hand. So I agree with your skepticism around the recommendations in terms of the options. My personal preference for management with patients would be dual bronchodilation as best I can. And in those with raised eosinophil count or other reasons why I might wish to add a steroid, I will add that in at a later stage. The challenge we have in South Africa is that we don't have access, easy access to a LAMA. So my COPD patients start on a LABA ICS as their first treatment option because we don't have easy access to a free LABA either. So we're doing it completely the wrong way around, and we're starting with a LABA ICS and in a sense adding in a LAMA when you're a frequent exacerbator, which in my mind is completely the wrong way, but we haven't managed to convince the government. So I think you're absolutely correct that in this space, the data is complicated. It's difficult to understand. The patients are difficult to understand. I'm not sure we have enough low middle income country patients in these trials either, because there's a lot more going on in our patients in terms of biomass fuel exposure, exposure to other infections, HIV, TB. So I hear your skepticism. And again, I think we need to take these data with a pinch of salt. And as I said, we need to have these discussions to say, how do we take these data and apply it to our clinical setting?
Okay, thank you, Lahore. If you have just one last quick question from Lahore before we move to the other cities. Any other burning question from Lahore?
Thank you very much, Dr. Javed. I have a question. Thank you very much, Dr. Richard, for a very nice and elaborate talk. My question is regarding the side effect of mometasone. As we all know, the inhaled corticosteroids, they do cause pneumonia in certain patients with the pneumonia, particularly in AB, and even some patient of the E group as well, as Dr. Wajid just now said. So my concern is, have you any head-to-head study of side effects of mometasone with other steroids, inhaled corticosteroids?
Okay, so it's a difficult question to answer, partly because the mometasone combination hasn't been well tested in the COPD group. So certainly if you look at budesonide versus formoterol, budesonide versus fluticasone, the pneumonia risk seems to be higher in the high-dose fluticasone group more so than the budesonide group. But in the COPD population as a group, there has not been a high exposure to mometasone. Certainly in the asthma trials, we haven't seen a lot of pneumonia. Obviously, it does exist. And it's difficult to fully understand the risk of infection, pneumonia side effects based on the asthma population. What we do know in the triple combination with indicatrol, glycopyrronium, and mometasone is that the mometasone dose is actually remarkably low. the drug in the so-called high dose is 160 micrograms of mometasone. Now, obviously, the number doesn't mean a lot, but that's in comparison to 400 twice a day, which you would use on its own. So I can't answer your question by any direct head-to-head trials in the COPD group, but I'm confident that it's no worse than anything else we've seen, and I would expect it to be a whole lot safer than a high-dose fluticasone.
Okay, Lahore will come back to you. And there are some questions from Karachi. Do you have a question in Karachi? Professor Nadeem Rizvi, Dr. Musawwar Ansari. Yes, Dr. Musawwar. Oh. Can you hear me? Switch on. Islamabad will come back to you. Just be patient.
Thank you, Richard. I think coming back from the steroids back to the llama, because the llama probably is the most important actor in the triple combination. We have number of these combinations now coming into the market. And my query was that just as we had a head-to-head trial of triotropium with glycopyrronium, the Astra trials, or the GLOW, which you mentioned, do we have a head-to-head trial between glycopyrronium and euclidinium?
No. I haven't seen any specific comparison. The other tricky issue with glycopyrronium is that it can be used twice daily. So there are some twice daily studies compared to once daily. The only data I'm aware of is the GLOW study, which again is set up as a non-inferiority. As I said, my personal bias is that it's better, but no, there is no head-to-head combination of which llama is worse. I do think, however, that UMEC and glycopyrronium are different to tiotropium. And I think in terms of the side effect profile, when we look at dry mouth and bladder prostate issues, my gut feel is we're seeing less with the so-called more modern llamas. I mean, there's absolutely nothing wrong with tiotropium, but I do think that the UMEC and glyco are potentially more potent llamas with slightly less side effects. But that's a gut feel rather than a head-to-head trial.
Thank you.
God, thank you.
Let me take you to Peshawar. I see Dr. Sadia and Dr. Zafar waiting there with the burning question. Dr. Sadia.
Sir, I'm Dr. Anila Basit, standing here on the dais. Sir, there's a very interesting
Dr.
question.
Anila, yes.
So there's a very interesting question from one of our PG, Dr. Zahir Ahmed. He is asking that if you talk about the comparison between different lavas in DPI, how indecterol is superior to formoterol in terms of rapid rise in the FEV1? Means how the indecterol is superior to formoterol, because I think study Professor Richard has mentioned one of the study.
So that's a very interesting question, and I don't have the answer because I can't find the data. So we know that indicatrol is exceptionally quick and it far outpaces salmeterol, but that's a bad comparison. That's asking whether a Volkswagen is faster than a Toyota. What we're asking here is formoterol versus indicatrol. I have looked and I have asked, and I cannot find any head-to-head data in terms of bronchodilator response between formoterol and indicatrol. What is interesting is that the indicatrol and the vilanterol are fast onset but work for full 24 hours, where formoterol does not. And if one looks at the mechanism of action of how these drugs actually work, even based on that, there isn't a clear indication why the indicatrols and vilanterols are so long-acting. I would love to see it. My gut feel is that it would work as fast as formoterol, but obviously can't be used as a reliever because it's a once-daily medication. So when you take it, you will feel it, and I think that's important for patient adherence, that they know the medication is working. But obviously it's not suitable as a reliever because of its long duration of action. But yeah, I don't have the answer and I have looked for it. So very interesting question.
Thank you very much for elaborate answer. One
Okay.
small question is side effects of mometasone. Somebody is asking here. The side effect
So I
profile of
think
mometasone.
the side effects of inhaled corticosteroids are all the same for all the inhaled corticosteroids. It's really a dose and a delivery perspective. And so if your inhaler technique is wrong, you're going to get oral candida from all of them. If your dose is too high, you're going to get side effects. And so for every corticosteroid, we need to use the lowest effective dose we can to reduce side effects. And I think it's very difficult.
In continuation to that question, sorry, thank you very much for answer. But in continuation to that question, one of our professor, Dr. Zafar, is asking that which steroid causes pneumonia more as compared to the other inhaled medication? Like we hear that in COPD, if you use steroids.
So the difficult question to answer, the drug with the most evidence is fluticasone because it's the comparator. So fluticasone 5500 is the drug that gets used in all the trials. So it is the one that has the most data showing it has the most harm. Doesn't mean that it has the most harm, it just has the most data. My personal feeling is that 5500 of fluticasone is way too high and causes lots of side effects. It seems to be worse than budesonide, but any steroid you use at high enough doses is going to cause trouble.
Okay, thank you, Anila from Peshawar. Let's move to Quetta. Dr. Maqbool, you have some questions there? Yes, Maqbool.
Hello. I'm Dr. Maqbool Ahmed, Associate Professor and currently as the General Secretary of Pakistan Chess Society. My question is that, Richard sir, your research efforts and contribution is very well appreciable. But here I am concerned that we are only focusing on drugs development in the form of inhalers, but we don't seem concerned regarding tissue repair and remodeling effects, which is the major problem in persistent airway inflammation. So is there any study that is being conducted regarding remodeling and this tissue repair?
So yeah, very important question. Just to stick with the asthma per se, at the moment there's a lot of interest in obviously the monoclonal antibodies in terms of directly dealing with airway inflammation. And there's interesting research being looked at early introduction of a monoclonal, which sounds crazy to spend several $1,000s on a treatment where you could use several $100s rather than thousands. But whether or not, if we can intervene with a monoclonal antibody earlier, whether we have long-term change in lung function. So that is a study that's currently being done in dupilumab to see whether or not it does have a long-term impact on lung function improvement. What we find difficult, I think, is to fully understand whether or not we have control of inflammation. And I think that's the challenge, is do we need to add more steroid? Do we need to add a bronchodilator? Pheno, to some degree, may or may not help. Lung function just reflects what's coming out, which we assume is because of airway inflammation. And I don't think we have a very good handle on detecting airway inflammation in situ that gives us a good handle on have we treated enough to prevent the very remodeling that you are talking about. Very much like pulmonary fibrosis, I think, unfortunately, once we have it, it's very hard to undo. And so for a disease like COPD, I'm not sure that there's a great hope that we will be able to undo the damage that has been done. And certainly our ability to detect inflammation that needs treatment is inadequate. And I think our therapy with corticosteroids works beautifully if you just give them a high enough dose. And if you put everybody on oral prednisone or injectable or corticosteroids, we would solve all inflammation, but we would destroy the rest of the body. So it's that clinical conundrum between how much do we need to prevent further damage. Whether there are new molecules, the newer development, the newer non-steroidal, non-corticosteroidal in anti-inflammatories that are being developed might be of benefit. I think we have yet to see those data coming out.
Thank you, Richard. Before I go back to Lahore to Professor Kamran Cheema, let me ask you a question. Based on the research that you did on the effect of vaping on the airways and lung, can you elaborate a little bit a message for the Pakistani youth who are now using vaping as an alternative, safer alternative to smoking? Please tell us, because we discussed that earlier and you mentioned that it's a big problem in South Africa, and certainly we are seeing in Pakistan as well. So, Richard.
Yeah, so thank you. Yeah, it's a very important question, and I should come and spend a week with you talking about vaping in adolescents. So I think I have a 3-message approach here. If you're a COPD patient who is smoking, then maybe vaping might be safer than smoking if you absolutely can't stop. But I can't promise that you're not going to drop dead of blue-spotted vaping lung disease in 5 years' time, because we just don't know. That's a very different context to an adult who hasn't chosen either, who then decides to start vaping. Because whether it's safer than tobacco is irrelevant. It's how more dangerous than fresh air is it. And there's clear evidence that vaping is more dangerous than fresh air. So there's no reason why an adult non-smoker should start. In the adolescent group, there are 2 major issues. One is obviously lung development. And so we just do not know what the long-term impact of vaping is. And what's different, there's some people in the room I see who's got gray hair like me. When I was at school, we had some of our boys at our school that used to smoke. They would maybe smoke behind the bicycle shed one day in the morning or afternoon, so maybe like a cigarette or 2 once or twice. What we're seeing with vaping amongst the adolescents at the moment is they're vaping before school, during school, in class, in chapel, in mosque. You can go forward, have a vape in your hand, go down for prayer, come back up, hold your breath for long enough. The vapor precipitates and you don't breathe out anything. So the amount of exposure that these young people are having to vaping products is way higher than we saw with tobacco. Now, what the long-term lung impacts are, I'm not sure. What's far more concerning for me in terms of adolescent vaping, and these are the data that I mentioned earlier that hopefully will be published in the next week or 2, is the mental health aspect, is the impact of nicotine on the developing adolescent's brain, on addiction, on neurocognitive function, on long-term anxiety, depression, and mental health. And nicotine is also a risk factor for infection. It has cardiovascular effects. So the amount of nicotine that's being exposed, I think, has a pleiotropic effect and will be interesting, unfortunately, to see what happens over the next 10 or 20 years. And we cannot sit by and watch our adolescents suffer the same fate that we did when our forefathers all said, oh, smoking is not bad for you, and we still stuck with cigarettes. I think we don't know the risks and need to come out very strongly to protect our high school students from companies that are looking for a new market.
Thank you, Richard. Thank you, Richard, for staying with us. Just in the last 5 minutes, we'll ask some, there are some 2-3 questions in addition to what has already been asked. So I now go to Lahore. I understand Dr. Khalid Waheed and his colleagues have some question in Lahore. Over to you, Lahore.
Sir, thank you very much, Professor Javed Khan Sahab. My question regarding the choice of inhaler and its impact on the disease progression. Because DPI usually needs forceful and deep inhalation, but MDI with spacer can be inhaled slowly with a deep inhale. And in the patient population like children, old age, obese patients, and patients with severe and refractory disease, what we have observed that they usually do better with MDI and spacers. This was our previous last decade observation. Now it's a part of guidelines as well, that before you select the inhaler, just check the patient's ability. What's your take on it?
Yeah, absolutely. I think one of the challenges that we have multiple challenges. One of them is that not all the combinations occur in all devices, certainly in South Africa. So you are often dependent on which device to have which medication. I know in different markets, it's not such a challenge. And I think you're absolutely correct. It's to tailor the device and the drug to the patient. In South Africa, we have two LABA ICSs, one made by a company that's blue and one that's made by a company that's pink. And I've said many times, particularly in adolescence, if you have a young lady who likes pink, then give her a pink inhaler. Don't give her a blue one, because if she likes pink, she will use the pink one. And so it may be far more important adherence than technique, because if they don't use it, they won't use it. But similarly, once you have got a patient using your device, I think inhaler technique is critically important. It can't be checked enough. And I've seen several times, I've got into trouble myself where I've said to a patient, oh, here's a new drug, new medication, different device, and they come back a week later and they've got oral candida because we didn't correct the inhaler technique. So I think we don't spend enough time dealing with technique, but sometimes we are forced to use devices based on the medication options we choose, and technique might be a secondary issue.
Thank you. Now over to Islamabad. Islamabad.
Hello, sir. Professor Javed.
Yes.
Last question from Lahore. Professor Richard, you just mentioned in your talk you use a double combination of bronchodilator, LABA, and inhaled corticosteroid in your patient from the start. I mean, but I think in group A and group B and even group E, you start this double combination. So have you seen any complications of which I have talked, just pneumonia in your patient of group A, which is totally against the guidelines?
Yep. So you're absolutely right. I mean, our doctors here would even start someone on budesonide on its own without a bronchodilator because they think it's asthma. So we have a major problem with access and a major problem with our primary care service using the correct choice. We have added concerns. Diabetes is high, infection is high here. And so it's difficult to always blame the steroid, but certainly it's completely unnecessary. And I spend a lot of time by the time they get to me to try and stop the steroid and leave them on a bronchodilator. So it is a concern, but it's often difficult to tease out the background rate of pneumonia plus TB from our steroid exposure.
Thank you. Over to Islamabad. Brigadier Baba Chima, you have a question? Just 1 minute. Your mic is not on.
Yes. Is it okay now?
Yes, we can hear you loud and clear, Babar.
Thank you. Dr. Richard, thank you for your talk. I just have a couple of comments and a quick question. Does mometasone, because of its unique metabolic characteristics, has any advantage over other ICS? Number one. Number two, I have a feeling that regarding the use of ICS, we need to overemphasize, or we can't emphasize enough in case of asthma, but we need to de-emphasize it in cases of COPD. And particularly with the advent of these molecules and triple therapy, do we run a risk of overuse of ICS in COPD, which I think we need to be guarded against because of the very limited value of ICS in COPD in a very particular group of patients? Thank you.
Yeah, so thank you. Very interesting questions. I've spent quite a lot of time trying to understand the differences between the inhaled corticosteroids, and it's tricky to try and work out which steroid has an additional advantage or disadvantage based on the molecular characteristics. I personally am not sure that any of them have a particular advantage over any other one, apart from ciclesonide, which has its unique pulmonary activation. I think there are, if you're getting into trouble with a particular inhaled corticosteroid from side effects or diabetes, it might be worth trying. But I'm not sure that I fully understand the subtle differences between them. In terms of your point about asthma and COPD, you're absolutely correct. I think the challenge is the differentiating the disease to actually tell someone you have asthma or you have COPD. So if you don't know what you're treating up front, then your treatment approach is going to be incorrect. So that's a challenge we need to deal with. And there are weirdly advocates for inhaled corticosteroids. So even if you just take a company like GSK, for example, they have a triple combination and a nice LABA ICS, so they will talk about inhaled steroids. You take a company like Novartis, who've developed a LABA-LAMA, they will talk about dual bronchodilation. So with even in the space, there are companies that have their own personal biases, which makes it quite difficult when you're looking at the data to tease out how important these things are. But I think you're absolutely right. For asthma, it's an inflammatory disease. There's burning coals in the lungs. We need to get rid of the inflammation. We need an inhaled corticosteroid. For COPD, you need a fire extinguisher to prevent the smoke from coming in, and then you need to bronchodilate the airways. And at some point, for some group, I think a steroid is useful. So the ultimate end point may look the same, but you get to that point from a very different perspective.
Thank you, Richard. Now a question from Professor Nadeem Rizvi of Karachi. Professor Nadeem Rizvi.
Thank you very much. Since you have insisting me to ask a question, Richard, I would like to know, because as you mentioned that you have got a lot of non-smoking COPDs, particularly biomass exposures. So do they behave differently as far as the use of these therapeutic agents in the treatment of smoking and non-smoking COPD?
Wow, that is a good question to hopefully end on. The short answer is that all of the GOLD guidelines recommendations only include patients who've smoked at least 10 pack years. So anybody who has not smoked enough does not get into these clinical trials. And so for the patients that we see who've had a bit of biomass, a couple of cigarettes, some TB, a bit of viral infection, there is no strong clinical trial evidence. So we need to extrapolate. My gut feeling, and we've done a little bit of work in this space, is that in the COPD type, I don't think that steroids are going to be very helpful. Also, I don't think in the post-TB grouping, you really want to be exposing them to high steroids. The pathophysiology is far more fibrosis than I think pure inflammation in the chronic setting. So I would tend to a dual bronchodilation approach, but that's not based on a lot of evidence. It's based on clinical experience where we would tend to go bronchodilator. But we just don't have the trial data because the companies that make these medications aren't particularly interested in our populations. But it's very important research to be done. The other challenge is to find clean groups to do it. Particularly in South Africa, for example, we have lots of TB, but we have lots of HIV TB, and they smoke. So we would need a pure population of biomass patients, a pure population of TB patients, a pure population of HIV patients, which aren't always that easy to trial. But it's a very important question, and I think we extrapolate far too readily from GOLD to our own populations in a low-income setting.
Thank you, Richard. We would like to continue, but in the interest of time, and I understand that you have to go to another talk, I just want to thank you on behalf of our President, Professor Shiri Khan, and General Secretary Dr. Maqbool, and on entire Pakistan Chess Society, I want to thank you for your time, precious time on this World COPD Day. I understand you are very busy in giving talks at a national and international level. So we all enjoyed your talk, and you answered question from all the panelists. And inshallah, we are going to see you at the next conference that we have in Pakistan of Pakistan Chess Society. So thank you very much. If you want to say last concluding words, please go ahead, Richard.
Yeah, thank you. I'm just delighted to be able to join you and share some data. It's a very complicated space. I think there's lots of discussion and interpretation of data that needs to be applied. And certainly, I think you've made me work hard with your questions. They haven't been easy questions, so it's always good to have those challenging questions, and thoroughly enjoyed being able to be with you. And yes, would love to be able to join you in future in person if that opportunity arises. And yeah, just I think have a really good rest of meeting. I think as all of us, many engagements, and so we'll step off. But thank you very much for having me. I really do appreciate the invitation.
Okay. Finally, thank you to the Highnoon team. I understand that a lot of effort were put in organizing this educational activity. So please, hands off for Highnoon team for organizing this educational activity. Thank you, Richard, and thank you everybody at Quetta, Islamabad, Peshawar, and Lahore. And here we end this session. And if there are any questions for the panelists from our local experts sitting here, they will be able to answer. So individually, all centers can respond to the questions of the audience sitting there. Thank you.
Okay, thank you.
So अस्सलाम वालेकुम. अच्छा, आपने प्रेजेंटेशन देखी COPD के ऊपर, होपफुली आपको मज़ा भी आया होगा. तो अब आप अपने पैनलिस्ट
ऑफ हो गए? ऑफ हुआ है?